Yes, Sandeep.
We are live, sir.
Okay, perfect. Good evening, friends. Welcome to Indian Arthroscopy Society webinar today. It's an interesting topic, and we are going to talk about skeletally immature athletes. A lot of young people are often involved into sporting injuries. They tend to develop ligament tears, especially the ACL tear, and also OCD lesions are pretty common in skeletally immature patients. We have our guest speaker today, Dr. Mininder S Kocher. Dr. Kocher is Chief of the Sports Medicine Division at Boston Children's Hospital. He's a famous name in pediatric orthopedic surgery, especially knee surgery for ligament reconstructions and skeletally immature surgery. He's professor of orthopedic at Harvard Medical School and president-elect of POSNA, the Pediatric Orthopedic Society of North America. Shreyash is briefly going to introduce our guest speaker today, followed by a 45 minutes talk of Dr. Kocher. For all of those who want to ask their questions, put your questions on IAS chat box so we can then forward it to Dr. Kocher and have a fruitful discussions today. Thank you, the panelists. Today we have a lead panelist of Indian Arthroscopy Society joining in. Shreyash, if you can kindly introduce our guest speaker today.
Hello, everyone, and welcome to webinar number 105 on the management of ACL and the OCD in the skeletally immature. Where are we today? With increasing participation of skeletally immature individuals in sporting activities, there is an increased incidence of knee injuries. The management of these injuries is challenging as children are not just young adults. And to share his experience and evidence on the management of ACL and cartilage injuries in this group, we have an internationally renowned expert in pediatric orthopedics and sports medicine, Dr. Mininder Kocher from Boston, USA. His clinical practice focuses on sports medicine and arthroscopic surgery of the knee, shoulder, hip, elbow, and ankle. He is the chief of the Division of Sports Medicine at Boston Children's Hospital and a professor of orthopedic surgery at the Harvard Medical School. He completed his residency at the Harvard Combined Orthopedic Surgery Residency Program and subsequently a fellowship in pediatric orthopedic surgery from the Boston Children's Hospital and in sports medicine and arthroscopic surgery from Steadman Hawkins Clinic, Vail, Colorado. He also attained a graduate degree from Harvard School of Public Health and Harvard Business School. His research primarily focuses on clinical epidemiology and biostatistics. He has published over 250 scientific articles, 100 book chapters, 6 textbooks, and has been a visiting professor in over 20 countries. He has received numerous research awards, including the Angela Coop Award, the Arthur Yoon Award, the Vernon Thompson Award, and the Kappa Delta Award, which is one of the highest orthopedic award in surgery. He has collaborated with the International Olympic Committee and the Aspen Institute. He has served in leadership positions with numerous organizations, including POSNA, founder member of PRISM, and the board of directors of AAOS and the AOSSM. He's also the president-elect for the Pediatric Orthopedic Society of North America, POSNA. He is a team physician for numerous organizations and is recognized as one of the best doctors in America. So on behalf of the Indian Arthroscopy Society, we are delighted and we welcome Dr. Mininder Kocher, and I would like to invite him to please share his screen and give us his talk on management of ACL and OCD in the skeletal immature. Where are we today? Thank you.
Well, thank you very much, Dr. Gajjar and Dr. Oberoi and the Indian Arthroscopic Society for the invitation to be here. It's a real pleasure, and I hope everyone is coping and staying healthy with the COVID crisis. I'm going to talk about management of ACL injuries and OCD and the skeletally immature. Where are we today? Welcome from Children's Hospital Boston and from Harvard Medical School. My mom is from, and my father, my mom's from New Delhi and my father from Punjab. And so when I was younger, we would come every summer back to India. And I greatly enjoyed these trips visiting family. And as an orthopedic surgeon, I've had the pleasure of returning to India, largely through the Pediatric Orthopedic Society of India, for multiple conferences and have greatly enjoyed reconnecting to India and orthopedic surgery in India. So for me, it's a real honor and a real pleasure to speak here at the IAS. My disclosures are shown here. I think there's no specific conflicts with this talk. In the United States, sports injuries in children are receiving great attention. And so this is the front page of the Chicago Tribune, a career-ending injury at age 11. This was a patient of mine with an ACL tear. This was the front page of the New York Times, big-time injury striking little players' knees. Another patient of mine with an ACL tear. San Francisco Chronicle, growing pains, children's sports injuries are getting worse. And this was ABC World News with Diane Sawyer, an 8-year-old patient of mine who had torn his ACL. And the background is that youth sports in the United States are changing greatly. So there's less free play. Kids are playing at greater intensity at higher competitive levels. They're focusing on a single sport at a younger and younger age. There's lots of involvement of adults, and the youth sports industry is really a large industry financially and driving many of these changes. If we look at the epidemiology in the United States, over 30 million children and adolescents are participating in youth sports, and over 3.5 children, just 14 and under, are receiving medical treatment. 5 to 14-year-olds are 40% of all emergency room sports-related injuries. But before we get very negative, we need to remember the benefits of youth exercise. So medically, lower rates of obesity and diabetes, better heart and bone health, and probably even more important, psychosocially, better self-esteem, lower rates of dangerous behaviors, and better career success later in life. And so we want to get these benefits of youth sports while avoiding the injuries. Specifically with respect to ACL, these injuries we are recognizing, and they are becoming more frequent in children and adolescents. Carl Stanitsky published this landmark paper in 1993, where he showed that half of traumatic hemarthrosis in skeletally immature patients were associated with ACL tears. We thought children got tibial spine fractures, they didn't tear their ligaments. More recent data, this is New York State insurance data in a study published by Emily Dodwell from HSS, and from 1990 to 2009 showed a threefold increase in the incidence of ACL injury in children and adolescents. This was a study we published in 2018 looking at children's hospitals in the United States, and you can see almost a fourfold increase in ACL surgeries in children and adolescents. This has been seen across the world, so this is data from the Australian registry looking specifically in children and adolescents, showing increased incidence of ACL tears from 2000 to 2015. This is from the Scandinavian ACL registry. And if you look at the second histogram here, you can see the largest proportion of ACL reconstructions in the Scandinavian registry are being performed in 11 to 20-year-olds. There is controversy, though, when we talk about ACL injury and treatment in pediatric and adolescent patients. There's controversy about the initial management. Should it be operative or non-operative? When it comes to operative management, what should the technique be with respect to the growth plates, which graft, how age plays a factor in this, and the concern about complications, specifically the risk of a growth disturbance. We recently had a consensus meeting at the IOC in Lausanne where we reviewed the data, and like many consensus meetings, we concluded that we need better prospective data on which to base these decisions. So what I'll do in this talk is we'll talk about ACL injuries, non-operative treatment, surgical treatment algorithm. We'll talk about the issue of growth disturbance, and then we'll pivot to OCD, talking about etiology, diagnosis, and non-operative and operative treatment. So if we start with ACL injuries in children, really the initial choice is to proceed with operative or try non-operative treatment. The advantages of non-operative treatment is avoiding surgery, but the disadvantage is you have an unstable knee. You're trying to restrict activity, often in very young, active children. That can be difficult to do and can affect them and the family psychosocially. And the main concern really is the risk of subsequent meniscal and chondral injuries. So with surgical treatment, the advantage is we have a stable knee with a lower rate of injuries, but there's risks specifically of growth disturbance. Partial tears of the ACL, I think we do see more frequently in children and adolescents than we do see in adults. This was a prospective cohort study we published on partial tears of ACL in skeletally immature patients, 45 patients, all treated without reconstruction. We followed them forward in time, and we found that about 70% did well and did not need subsequent reconstruction, and 30% went on to need subsequent reconstruction. And if we looked at risk factors, again, this is for partial ACL tears, the older children did less well with lower survivorship. The greater the extent of tears, so over 50% tears, did less well. And the location of the tear was important. So those tears on the posterolateral bundle did less well than those in the AM bundle. What about complete tears? And so in multiple series of complete tears, the findings are very similar. So there are high rates of instability, increasing rates of meniscal tearing and articular cartilage with non-operative treatment of a complete tear. Todd Lawrence and the group from CHOP showed with a delay of over 3 months, increasing rates of meniscal tears, chondral injuries. Alan Anderson showed, again, with over 3 months, increasing rates of instability, meniscal and cartilage injuries. And we found a similar finding showing almost 6% increased risk per month of meniscal or chondral injuries, because these young children are very active, and it may not just be from organized sports, it may be from free play or play at school as well. In addition just to the number of meniscus tears, the type of tear may change as well. And so this is data showing less than 12 weeks surgery from the injury time. 87% had no tear, and the majority of tears were a repairable pattern. Whereas over 12 weeks, only 65% of patients had no tear, and the majority of tear patterns were irreparable tears. I think this is what we see with the data and anecdotally. The group from Oslo, Norway, Lars Engebretsen, Håvard Moxnes, Mara Lee Reisberg have looked at copers, so trying to find copers in the pediatric patient population. And in multiple well-done prospective studies, they have found that some patients are able to cope with an ACL injury, but many patients have to reduce their activity level. So 38% in this one study reduced their activity level, and there were high rates of subsequent meniscal and chondral injuries. So in this study, a third went on to ACL reconstruction. Almost 30% had a meniscal tear. And then between the initial and follow-up MRIs, another 20% went on to tear their meniscus. So there may be copers, but the real concern is meniscal and chondral injury. These are 3 cases that we just had in the last month that are illustrative. All are prepubescent children. This is an ACL injury, a complete proximal tear that we treated approximately 3 weeks after injury. Normal cartilage and meniscus. We did a physeal sparing ACL reconstruction with IT band. Another injury that we treated with surgery at about 5 weeks from the initial injury. There is a meniscal tear here, but this is a repairable pattern. And again, we treat with a physeal sparing ACL reconstruction technique. This is more typical in the chronic scenario. So this patient was about a year from their ACL injury, treated non-surgically with recurrent episodes of instability, pain, and swelling. So now at the time of surgery, we have an irreparable meniscal tear pattern, full thickness articular cartilage injury. And we can do a physeal sparing ACL reconstruction, but we worry a lot more about the long-term health of this knee. So I would say in the United States, definitely the pendulum has switched to operative treatment instead of non-operative treatment for these injuries because of the risks of meniscal and chondral injuries. So if we get to surgical treatment, what are the options? The menu is shown here. We have extra-articular procedures alone, procedures that spare the growth plates, procedures that go through the proximal tibial growth plate, but over the top or in the epiphysis on the femur, and procedures that go through both the distal femoral and the proximal tibial physes. If we look briefly at this literature, extra-articular alone showed poor results in skeletally immature patients, like it did in adult patients. Primary repair in skeletally immature patients also showing poor results as in adult patients. I think there are new developments in repair of the meniscus. So this is Martha Murray from our group who has pioneered the BEAR technique, bridge enhanced ACL. So this is a primary repair with a bioengineered sponge device injected with whole blood. This has showed excellent results in the pig model in terms of stability and low rates of arthritis. And in our randomized trials in the United States is showing good results at 2 years. So this is definitely something to keep your eye on coming in the future. Physeal sparing techniques have been described. This is a technique using the hamstrings over the front on the tibia, over the top on the femur, so avoiding the physis but non-anatomic. Professor Gazzanti from Rome developed this technique with an epiphyseal tunnel in the tibia to an epiphyseal staple in the femur. Alan Anderson described this technique with epiphyseal tunnels, avoiding the growth plates in the femur and tibia. And we've described this technique with the iliotibial band, intra-articular and extra-articular, avoiding the growth plates. Partial transphyseal techniques have been described going through the proximal tibial physis and either over the top on the femur or an epiphyseal tunnel on the femur. And then a variety of techniques, transphyseal, both through the distal femur and the proximal tibia. The problem though with the literature is that these series are small, retrospective, so a low level of evidence. Growth remaining is not well documented. Many studies just include chronological age, not the patient's skeletal age or physiological age, and many studies do not include their pre-op alignment. I think it's very important in this patient population to think beyond chronological age. So these boys on the left are all the same chronological age, but this boy is in a very different physiological stage than this boy. These girls are the same chronological age, but this girl is in a different physiological stage than this girl. So we need to be thinking about skeletal age. We can get to skeletal age with the Grulich and Pyle Atlas or Tanner physiological staging of secondary sexual characteristics. We need to remember that the majority of growth is happening from the distal femoral and proximal tibial physis in the lower extremity, and with growth and development in childhood, we're seeing coronal plane and rotational plane changes as children grow. The concern obviously is the risk of a growth disturbance in the animal models of transphyseal reconstruction. We have seen growth disturbances in rabbit and dog models, and there had been 2 reports in clinical series. We published this paper in 2002 surveying the Herodicus Society and the ACL study group. And in this paper, we characterized 15 cases of growth disturbance, 8 cases of valgus with a growth arrest, 2 cases of valgus without a growth arrest, 2 cases of leg length discrepancy, 1 a shortening and 1 an overgrowth, and 3 cases of recurvatum because of an injury to the tibial tubercle apophysis. When we looked at these cases, the recommendations were fairly straightforward. So avoid hardware, bone plugs across the growth plate, avoid large tunnels, be careful in the over-the-top position because of the perichondrial ring, and consider modifying your technique based on the amount of growth remaining. These are growth disturbances we've seen recently. So this was a 14-year-old male. These are the pre-op films with normal alignment, had a transphyseal ACL reconstruction with fixation away from the growth plates, at 10 months postoperatively went on to failure with a valgus deformity of the knee. This was treated with revision ACL reconstruction with guided growth with an 8 plate. Another case, so this is a 10-year-old, so now a prepubescent who was treated with transphyseal reconstruction with hamstrings, now seen at age 16 with a severe valgus deformity. This required with a growth disturbance. So you can see the growth disturbance of the distal femur from the transphyseal tunnel, open proximal tibial physis. This was treated with staged osteotomies and revision ACL reconstruction. Another case of a prepubescent patient treated with transphyseal reconstruction with a growth disturbance on the tibia. So you can see a varus deformity with a recurvatum deformity, and this was treated with a Taylor spatial frame for lengthening and angular correction. We looked at 43 cases of transphyseal ACL reconstruction with hamstrings using MRI with a physis technique, and we found that focal bone bridges were common, but if they involved a small percentage of the physis, we did not result in growth disturbance. All epiphyseal ACL reconstruction also has had case reports of growth disturbance, valgus deformity, and growth arrest, as shown here on the left, or an overgrowth has been seen in multiple series. So drilling epiphyseal tunnels near the physis may stimulate the growth plate and result in overgrowth. So what's our treatment algorithm? I would say the largest group of patients we see are adolescents. So they've hit puberty, but they have open growth plates. And so these are often Tanner stage 3 or early stage 4, males skeletal age 13 to 15, females 12 to 14. And again, this is a large percentage of our patient population for ACL reconstruction. In this population, we recommend a transphyseal ACL reconstruction with soft tissue, autograft, usually hamstrings, and fixation away from the growth plate. So this is typically suspensory fixation on the femur or the tibia, or a interference screw that's below the physis on the tibia within the metaphysis. We published our results with this in 2007 with good functional results and no cases of growth disturbance. Since then, we've modified our femoral technique, so drilling through the anterior medial portal. I think this gives us a more oblique tunnel across the physis, so you have to be careful of this obliquity. And another option would be the partial transphyseal technique, where we do a tunnel within the epiphysis. However, our graft makes a big turn here as we drill our epiphyseal tunnel in the femur. I think the more vexing situation is the prepubescent patient, and we see this more and more frequently. So these are Tanner 1 and 2 children, males 12 and under, females 11 and under. And in this patient population, the options include non-operative treatment, but again, they don't do well with meniscal and chondral injury. You can go transphyseal, but if there's a growth disturbance, it's very significant. Epiphyseal tunnels have to be careful of this turn and also overgrowth on the femur. We've used this modification of the McIntosh procedure using the iliotibial band with an extra-articular component and an intra-articular component. This is a video showing this technique. So this is typically done under general anesthesia with a regional block. We make a lateral incision. We're now separating the subcutaneous tissue from the IT band. We make incisions towards the anterior posterior borders of the IT band. We need a fairly wide portion of the IT band because it's very flat to get volume for our ACL reconstruction. We're using these meniscal knives to carry this incision proximally under the skin. The alternative is to use a larger tendon stripper that has a cutting function. This is a modified tendon stripper as well. So we run this underneath the anterior and posterior borders of the IT band and detach proximally. We're typically looking for a 14 to 15 centimeter length of the IT band to have sufficient length for both extra-articular and intra-articular ACL reconstruction. So we've detached this proximally and whip stitched. We're now dissecting distally, leaving the graft intact towards Gertie's tubercle and leaving the capsule intact just underneath the IT band. We're bringing this graft through the knee in the over-the-top position. This is the external picture, and we'll see the arthroscopic view. So we're bringing our graft through the knee in the over-the-top position. This will be the extra-articular component with the IT band that's really reconstructing the ALL, the interlateral ligament. And now on the tibial side, we've made a groove here in the tibia epiphysis. So we make this groove to facilitate healing, also to bring the graft in the anatomic position on the tibia to avoid impingement with extension and hyperextension, as many of these young children have. So now we're seeing the graft come through the knee within this epiphyseal groove under the intermeniscal ligament. We're pulling it through this small incision on the tibia. And so here's the intra-articular component of the IT band graft. And then we can extend the knee and make sure we have full extension without impingement of the knee. We fix the lateral extra-articular component first with the knee at 90 degrees of flexion, and we suture to the intermuscular septum and the periosteum of the distal femur. And then here on the tibia, we've made a periosteal incision, and we suture the graft to the periosteum. We roughen the bone. This is just medial to the tibial tubercle apophysis. We like this method of fixation because the graft heals to the periosteum, and with growth, we have a more biologic method of fixation. And so the graft can grow as the child grows. And we have MRI studies showing growth and increase in the width of the graft with growth. We published our results with this technique in the prepubescent patient, originally in JBJS 2005. 44 patients, average age was 10.3 years old, 5.3-year follow-up. We had a low revision rate, high functional outcomes, and no cases of growth disturbance. We followed this up in 2018 in JBJS, 240 knees. Interestingly, the majority are males, whereas in our adolescent population, the majority are females. Average age here was still very young, 11.2. Follow-up was 6.2 years. We also found a low revision rate, 7.0, 2% arthrofibrosis rate, 10% rate of contralateral ACL injury, 6% rate subsequent meniscus surgery. IKDC, Lee-Shom scores 93. Return to sports was very high, 97%, 84% at the same level, and no cases of growth disturbance. Biomechanically, this technique has been looked at compared to other techniques and restores the native state most promisingly. And this is likely because of the extra-articular component of the reconstruction, where we are essentially reconstructing the ALL. So in summary, with regard to ACL injuries, the child's not a little adult. The child athlete's also not a little adult athlete. When treating these patients, it's important to know the growth remaining, undergo a process of shared decision-making, understand the pediatric knee anatomy related to the physis and the tibial apophysis. Consider modifying your technique. We do a transphyseal technique in adolescence and a physeal sparing technique in prepubescence. Prevention is a real opportunity in these patients. So the majority of ACL reconstructions we saw in Scandinavia, but also in the US, are in this adolescent population. So this is our group. We should be working on ACL prevention, either through educational programs like Stop Sports Injuries, which we developed in the AOSSM, but also hands-on injury prevention techniques. This is our McKaylee Center for Youth Sports Injury Prevention, where we have ACL injury prevention programs. We do need better data for this injury. This is the PLUTO prospective multi-center cohort study that we conceptualized in 2005 and started enrollment in September in 2016, following on the success of Moon and Mars. For this study, we had to modify the IKDC to be an appropriate outcome instrument for children in adolescents, and then validate the PD-IKDC. So this study is a prospective cohort study at 10 centers, and we assess growth remaining, failure rates, growth disturbance, functional outcome, health-related quality of life, and activity level. These are the 10 centers. These are the treatment algorithms. We have prepubescent and pubescent patients. We have 5 treatment arms: non-operative, transphyseal, partial physeal, 2 physeal sparing techniques, the IT band, and epiphyseal tunnels. These are our treatment flow algorithms, and we've standardized all these aspects. We just stopped enrolling over the summer, and we have 763 patients that we now are following out to 10 years. We're getting our 2-year follow-up data in the earliest group of patients. So hopefully with the PLUTO study, we'll have better data and we can avoid this cartoon. Let's just start cutting and see what happens. So with that, we'll pivot to a discussion of OCD, osteochondritis dissecans. We'll start with a case, which is pretty typical clinical scenario. So this is the arthroscopic view, skeletally immature adolescent patients, the lateral aspect of the medial femoral condyle. We have an unstable OCD lesion with a soft tissue hinge here towards the intercondylar notch. So what do we do for this patient? Non-operative fixation of the lesion. Do we drill it? Do we bone graft? What's the role of PRP? Do we take it out and do a mosaicplasty or allograft or ACI or MACI procedure? These are all questions. I think it's an interesting time to revisit OCD. So in the past, this is a picture from our institution. Patients were treated for up to 2 years with a orthotic to bypass the knee. OCD, it was imaged with bone scan. When it came to surgery, it was open, largely with excision of the OCD lesion. So nowadays we have better ways of imaging OCD with MRI, and we have arthroscopic treatments, and we have more biologic treatments. We're seeing it more frequently in children, and we're seeing OCD at a younger age, and now more commonly in female children and adolescents as well. I think it's important to understand what we're talking about with OCD. OCD is not an acute osteochondral fracture. It's not an isolated cartilage injury. It's not an accessory center of ossification or epiphyseal dysplasia. When we talk about OCD, we're thinking more of a repetitive condition that involves the subchondral bone and secondarily the articular cartilage, and can lead to instability and separation of the fragment. We did a CPG with the AAOS on OCD, and this was fairly discouraging. We didn't have good data for conclusions in terms of many aspects of evaluation and treatment of OCD. This led to formation of the ROC study group, which we started in 2008, and now is 23 centers, 32 surgeon investigators to get better data and understanding of OCD. Our ROC definition of OCD is a focal idiopathic alteration, subchondral bone, risk for instability and disruption that may result in premature osteoarthritis. What's the etiology? Osteochondritis was coined in 1888 by Koenig, implying inflammation. This is probably not a primary inflammatory condition. Probably the most common etiology is repetitive microtrauma. Ischemia was suggested by Anna King in 1980. It does bear resemblance to some ossification abnormalities, and there may be families in which OCD runs genetically in the family. Also may be related to endocrinopathy. Histological studies have really shown variable findings in terms of etiology of OCD in terms of repetitive trauma or poor blood supply. OCD may occur after a bone contusion, so a bone bruise with healing may go on to develop an OCD lesion. This has been reported in cases with follow-up MRIs. Or it may be a disruption of what's called the secondary physis. So this is the physis that occurs within the epiphysis, not the primary physis between the epiphysis or the metaphysis. These are all current things that we're looking at. Diagnosis of OCD, the diagnosis completely depends on the stage of the lesion. So in early stage lesions with intact cartilage, the history may just be vague knee pain. In later stages, we see catching, locking, swelling. Patients may walk with an external rotation gait to avoid impinging the medial femoral condyle on the intercondylar spine. They may have an effusion. They may have pain to palpation of the location of the OCD lesion. The most common location, so almost 64% of lesions are going to be the lateral aspect of the medial femoral condyle. Second most common, about a third of lesions on the lateral femoral condyle. And then we see a variety of lesions, including the patellofemoral joint. I think in terms of radiographs, the key point here is to remember to get the notch view in children and adolescents with knee pain. So this is the same patient with an AP X-ray and the notch X-ray clearly showing the OCD lesion. And this is because the majority of the OCD lesions live more posteriorly on the femoral condyle. So with an AP X-ray and extension, you may miss the lesion, but with the notch view and flexion, it's more apparent. MRI is the main way we image OCD lesions at this time. And with a good MRI, you should get information about the articular surface, whether there's a breach, the stability of the lesion, and the chronicity of the lesion. The most common classification system on MRI is the Hefti classification. Fritz Hefti from Basel, Switzerland. So stage 1 have intact cartilage, no margin. Stage 2, intact cartilage, but marginated. Stage 3 is partial dissection of the cartilage. Stage 4 is unstable, and stage 5 is a loose body. So this is an AP X-ray and a corresponding coronal MRI. We can see the articular cartilage is intact, but this is well marginated. So this would be a stage 2 lesion. We developed a novel classification arthroscopically for the ROC study group that includes a description of the lesion. So we have a cue ball lesion with no abnormality detected arthroscopically, a shadow lesion where the cartilage is intact but shadowing, a wrinkle lesion, cartilage is demarcated with wrinkling. We then have mobile lesions, so a locked door where there's a fissure in the lesion but it's stable, a trap door where there's a fissure and it's unstable but attached, and then a crater, a loose body type lesion. We looked at the reliability, inter and intra observer reliability of this classification system, which was valid. So what about non-operative treatment? I think non-operative treatment is indicated for stable lesions in skeletally immature patients because there is healing potential. Treatment may consist of activity restriction from impact sports, protected weight bearing, use of immobilization or an unload or brace. And the length of treatment in the literature is varied from 3 to 12 months. Non-operative treatment can work. This was an intact lesion treated non-operatively, which went on to healing. Similarly, a lesion with intact cartilage but marginated that went on to healing with non-operative treatment. The problem, though, is that not all lesions will heal. Even in this large series from Cahill from Chicago in the 1980s, 43% of the lesions went on to not heal. We did a prospective study with 3 groups: casting, activity restriction therapy, activity restriction and therapy alone, and unloader bracing with activity restriction and therapy. And these patients were treated with an algorithm. We found 62% went on to heal, meaning about 40% went on to not heal. And the predictors of unsuccessful non-operative treatment were older patients, larger lesions, more chronic symptom duration, and a higher Hefti stage. Similarly, Eric Wall in a prospective study found that similar risk factors, so patient age, larger lesions, and more chronic presenting symptoms, they found 66% went on towards healing, whereas 34% went on to not heal. So in the Cahill series, our series, and Eric Wall series, you're all seeing about 40% of these lesions will not heal with non-operative treatment. What are the predictors? skeletal maturity, so older patients do less well, larger lesions do less well, lesions outside the medial femoral condyle do less well, and more chronic lesions do less well. So that leads us to surgical treatment. Surgical treatment is indicated for unstable lesions as the initial treatment, or for stable lesions if they've failed non-operative treatment, and we just said 40% will fail non-operative treatment. What are our techniques? They're shown here. We can drill the lesions, fix them, remove them, and chondral resurfacing. Drilling, the rationale is to enhance vascularity. So this is typically done for stable lesions with an intact surface. These can be drilled through the articular cartilage, so transarticular with a small wire, or retroarticular, so using fluoroscopy from within the epiphysis behind the lesion, avoiding the articular cartilage. We've published on this, and others have as well, with high healing rates for stable lesions with intact articular cartilage that failed non-operative treatment. What about fixation? The rationale is to treat this almost like a fracture. So to give stability, often drilling is done in addition to fixation. This can be done with antegrade or retrograde techniques and a variety of hardware. So screws, variable pitch screws, wires, tacks, and now bioabsorbables as well. Bone grafting can be added for more chronic lesion. We published our results with fixation in 2007. And interestingly, I think our main finding was 85% of these lesions went on to heal with fixation, including all 6 stage 4 lesions. These were lesions that were detached, so loose body type lesions. So the message we got from this study was to try fixation in these skeletally immature patients, because many of them will go on 85% to heal, and that may be better to keep their own cartilage than a chondral resurfacing type procedure. What about excising the lesion? I think sometimes we do have to excise the lesion. We have a loose body, particularly a chronic loose body, which may be avascular. It may have grown and no longer fits in the underlying base. This is typically done with some sort of marrow stimulation procedure as well. The prognosis with excision alone is quite poor because you're removing a large part of the articular surface, so the risk of arthritis is high. So typically if you're excising a lesion, we now think of chondral resurfacing as well. So chondral resurfacing would include techniques like microfracture, although this is not a typical microfracture because often the subchondral bone comes out with the OCD lesion. So it's more of a marrow stimulation. Mosaicplasty is an option. However, these lesions are often large, and this requires multiple grafts. So you get a snowman or a cobblestone type of appearance. Osteochondral allograft, for us, this is a good technique for the larger lesions because you're bringing in bone and cartilage. ACI, we've done this as well with a sandwich technique involving bone, ACI cells, and a periosteal patch, and now Macy techniques as well. Results are not clear as these are all smaller series of chondral resurfacing techniques. So our conclusion with respect to OCD is to treat this algorithmically. Stage 1 and 2 lesions, we do try non-operative treatment. Some of these will fail 40% and go on to surgical treatment. Now, if we have a large lesion, chronic lesion, cysts, location other than the medial femoral condyle, we may proceed right to surgery because their chance of healing is lower. Unstable lesions, stage 3, 4, and 5, we go to surgery. This includes drilling, fixation, possible bone grafting. If we have to remove the fragment, chondral resurfacing types of techniques. What's in my bag of tricks? So now bioabsorbable implants, tacks, headless screws, also use metal screws, headless and headed screws, bone grafting for chronic lesions. For chondral resurfacing, smaller lesions, I like oats because you're bringing in bone and cartilage. And for larger lesions, typically osteochondral allograft. We need to think of these patients and follow them for long-term consequences, including osteoarthritis. The future hopefully holds an animal model where we can look at different techniques better treatment, equipment, bioabsorbables, more biological treatment, bone, vascular factors, stem cells, and better techniques, including scaffolds for bone and cartilage. Again, prevention would be very important in this patient population, prevention through educational and interventional programs. I'll leave you with this thought. OCD of the racehorse, particularly quarter horses and thoroughbreds, because these are juvenile athletes, had been a big problem. This is one of my good friends, Wayne McElraith from Colorado State University, and I get to operate with him and spend some time with Wayne and looking at OCD in racehorses. This is the stifle joint of a juvenile racehorses. They've been able to reduce the amount of OCD in racehorses by controlling the amount of activity, making sure the racehorses warm up and warm down, proper nutrition, making sure they're getting plenty of rest and sleep, minimizing stress, and then early stem cell injections. And so maybe we should treat our children like racehorses. These are our children who are all engaged in athletes, and these are actually our horses. So I think prevention, again, just like ACL, is a real opportunity with OCD. So I'll stop there and thank you again very much for the invitation and thank you for your attention.
Thank you, Dr. Kocher, for that excellent overview on both topics. I'll just now invite my colleagues to ask questions, and then subsequently I have a few at the end. IPS?
So Raghuveer can start if he has any question. Tejas?
Dr. Mininder.
Okay, Menon can start.
Dr. Mininder, can I ask? Yes?
Yeah, sure, please. Dr. Menon.
During the facial sparing reconstruction method using IT band, you said you're going to fix the extraarticular part. In which angle you fix it, and what is the to which portion you fix it? You said intramuscular septum. That I didn't follow that.
Yeah, so we are fixing with the IT band reconstruction, the extra-articular part, we're typically fixing with the knee at 90 degrees. You want to avoid increasing the external rotation, because if you fix it in external rotation, you actually can over-constrain the knee and limit the internal rotation. So we typically fix it in whatever rotation the knee lies in at 90 degrees of flexion. The graft is attached to Gertie's tubercle, and then we're fixing it near the over-the-top position. So it's really to the inner muscular septum and the periosteum of the distal femur near the over-the-top position. So it's posterior to the lateral epicondyle.
Yeah. Mininder, in young girls with hyperextension or lax knees, are there any special things we are going to do when you do a ligament reconstruction?
Yeah, I think that's a really good question, and that's a challenging situation. So if you do an ACL reconstruction in a patient with hyperextension, say they have 20 degrees of hyperextension in both knees, and you do an ACL reconstruction and they get to 0 degrees extension in their surgical knee, they will be unhappy because they are asymmetric. On the other hand, we don't want them to get back to 20 degrees of hyperextension because that probably increases their risk of re-tearing the graft. So I think that's a very challenging situation. My goal in those patients is to get some hyperextension, but not maybe the same amount. So maybe 10 degrees hyperextension, et cetera. I think that population, the adolescent female with hyperextension, is probably the group that has the highest re-tear rate after ACL reconstruction. So with hamstrings, it may be as high as 15 to 20%. So that's the patient population that we really look at now, and to do a ACL reconstruction intra-articular and adding an extra-articular ALL reconstruction. Some of the studies, including the Santee study, have shown a reduced risk of re-tear using the ALL.
So is it usually an ALL or sometimes an LET as well?
Yeah, so I think either ALL, LET, or even, switching your graft to a patellar tendon graft in that population, which tends to be more stiff.
Okay.
Have you seen that after a year or so, these girls who are having hyperextension and put a slightly tighter graft, they do become all right? Means they have similar extension at the end of 1 year.
I think that they often do. So they can, particularly if they have generalized ligamentous laxity, or if they have a collagen disorder like Ehlers-Danlos syndrome, they tend to go back to their hyperextension. But I think in the patients without generalized ligamentous laxity who do have hyperextension of the knee, we often get them back to hyperextension, but not the same amount of hyperextension as their other knee. So it's really a really gray zone. You want to get them, you need to get them past 0 because they will be very unhappy. It's like a patient who has 0 degrees on the other knee getting to a 10-degree flexion contracture. They're not happy. However, I don't think you want them to be really big hyperextenders.
What are your tips for the transphysial reconstruction with hamstring graft in a pubescent age group around 11 to 14?
Yeah, I think the tricks are being okay with a smaller graft. So our grafts are usually 8 or 9. But if you have a pubescent, say, female who's not very big, a 7mm graft might be perfectly appropriate for her knee. I think, when we look at registry data and we see a higher failure rate in grafts under size 8, I think that can be deceptive. It needs to be the size of the graft relative to the size of the knee. So sometimes a 7mm graft is just fine. I think when we drill our tunnel on the tibia, we want to go slightly more vertical. So I usually drill at 50-degree angle or a 55-degree angle instead of a 45-degree angle. And then on the femoral side, we do drill through the anterior medial portal, but you want to be careful of that obliquity. I think particularly if you drill outside in, like with a flip cutter, you can get very low and have a big oblique drill across the physis. And so I think anteromedial is a little bit more safer. And in the beginning, you might want to check X-ray to see your obliquity across the distal femoral physis, and then definitely keep your fixation away from the physis. So some suspensory fixation on the femur and either a post or suspensory on the tibia. Oftentimes you have enough room below the physis on the tibia for a 20 or 23mm length interference screw.
Okay, thank you.
Tejas has a question. Tejas.
What is your rehab protocol after ACL?
Keep your microphone close, Tejas.
Yes, sir. Sir,
Yeah,
what
better.
is your rehab protocol after your ACL reconstruction in the pediatric age group in which you didn't fix the tibial part and the femoral part with the implant, but suture to the periosteum and all?
Yes,
Yeah.
I think the question was on rehab protocol for the physial sparing technique. So in that population, we go a little bit slower because our fixation's not as rigid. So we typically keep them on crutches for 4 weeks after surgery instead of 1 or 2 weeks. We limit their motion. So we go 0 to 30 for 2 weeks, 0 to 90 from week 2 to week 4, and then full range of motion. They end up at the same place, but they're a little bit slower in the beginning. Our return to sports is usually, we test all our patients functional testing at 6 to 9 months. I would say most of the hamstring patients and even our patellar tendon patients, we're releasing back to sports at 9 months after surgery. This IT band group often, though, at 6 months have no functional deficits because we haven't interfered with the flexion or extensor system of the knee, and they're ready to return to sports at 6 months.
Mininder, we do get chronic ACL avulsions in kids. They usually come maybe around 2 to 3 months later, and they tend to develop a fixed flexion deformity. We are able to put it back, but we are unable to correct the FFD. So are there any tips, any kind of posterior releases you do for such cases?
Yeah, I've found, so this is often the case with tibial spine fracture. that a chronic tibial spine fracture, and they may lack extension. Sometimes it's because of the bony block, so the pieces in the knee preventing extension. Other times it's from contracture. Tibial spine fractures, surgical or non-surgical, have a high rate of arthrofibrosis. And so if it's a bony block, it's pretty simple. You go in, freshen up the fracture. You actually can take some bone in the bed to over-reduce the fracture. We usually use sutures, or you can use screw fixation, and you typically will get your extension back. If it seems like the contracture is more from arthrofibrosis, then I will often take them to the OR to do a manipulation under anesthesia, scope lysis of adhesion, CPM, get their motion back, and then come back and do their tibial spine fracture when they have better motion.
Perfect. Dr. Menon, you have a question?
Thank you, Dr. Mininder, for the nice talk. How will you basically come to the clinical diagnosis of a ACL injury in a pediatric population? Because often the history won't be very conclusive, and also due to increase in the physiological laxity, the test may not be reliable. So how will you primarily come to a diagnosis? Is it a clinical or is it image diagnosis?
Yeah, I think that's an excellent question. I think the first thing is just to remember that the kids and adolescents do get ACL injuries. I would say in the 1990s, even early 2000s, we were thinking that kids don't typically get this injury. They really only get tibial spine fractures. So have it on your mind that they can get this injury. That's important. I think on exam, their history is often the same. So a pivoting contact or non-contact injury, they hear a pop and they have a large hemarthrosis. When you see that patient, think ACL, think tibial spine, but also remember patellofemoral dislocation. That will often have a pop and a swollen knee as well. X-ray can tell you if they have a tibial spine fracture or not. On physical exam, they can be loose. And so it's very important to examine the contralateral knee to know what their baseline is. But beyond their baseline, they will have increased laxity. Sometimes children, it's hard for them to relax, so you can't get a good Lachman, particularly a pivot shift test. And so MRI can be very helpful to confirm the diagnosis.
Have you any time met with any surgical surprises, like in drop, your diagnosis has gone wrong, or you didn't find anything what you expected clinically or in the MRI? Any sort of that?
That's not very common. I think that the surprises we see may be an unexpected meniscal or cartilage injury, but we can treat that at the same time. So I think particularly if you've got the history, the physical exam, and the MRI that's confirming it, you kind of know what the primary injury is. And I think some of the secondary injuries, meniscal and cartilage, we can treat at the time of surgery.
Thank you, Doctor.
How often is the quadriceps tendon graft used in pediatric ACL reconstructions?
Yeah, I think the quadriceps tendon graft is being used more and more in the United States, but it's still very early in the experience. And at our institution, 2 of our 8 sports medicine surgeons use quadriceps tendon graft as their primary ACL graft. And so I think you can use the quadriceps tendon graft for transphyseal reconstruction or even an epiphyseal reconstruction in this age group as well.
Yeah, Shreyash.
Tejas has a question, so I'll let him ask and then.
Yeah, Tejas.
Sir, my question is your technique of the ACL reconstruction. You make a bony tunnel or just pass the graft through the behind the intermeniscal ligament and subcutaneously?
Yeah, so with the physeal sparing technique, we're not drilling a tunnel across the physis. So on the femoral side, the graft is coming in to the knee through the over-the-top position. So that would be slightly more posterior to the anatomic position. But actually, you can have it in a more anatomical position in terms of how low it is. So you can get low with your graft, but it is more posterior. On the tibial side, we make this epiphyseal groove within the tibial insertion of the ACL. And that really lets the graft heal in a anatomic position on the tibia. It's almost like a tunnel, really. And if you drill a tunnel in the tibia and you try to keep it in the epiphysis, it's a challenge, and it is a very shallow tunnel. And so this is like a tunnel in the epiphysis on the tibia, and then it goes under the intermeniscal ligament.
So you suture the graft at the back of the femur also to keep it that place only?
Yeah, so we suture the graft at the femur, and that fixes the graft at the femur near the over-the-top position for both the extra-articular part and the intra-articular part. And then on the tibial side, we're suturing it to the periosteum of the proximal tibia.
So what is your technique to make a groove on the anterior part of the tibia?
We use a rasp. So we use a rasp that's called a rat tail rasp. And we basically do that under arthroscopic visualization. You don't want to go too deep because you could injure the proximal tibial physis, but it's typically, 10 to 15 millimeters deep.
Did I see in one of your slides that you mentioned that you have published this technique in the Video Journal of Orthopaedics, right, in 2016, in case any of my panelists want to visit and get more details on it?
Correct. I think it's there, Video Journal of Orthopaedics. It's also on the POSNA, POSNA, Pediatric Orthopedic Society North America website. We have educational videos there as well.
Great. So
POSNA Academy. Sorry, POSNA Academy.
POSNA Academy. That's great. So firstly, congratulations on your work on the physial sparing technique. I just have two questions regarding that technique. One is, what is the incidence of muscle herniation because we're taking the IT band out? And secondly, what happens to the IT band as the child grows?
Yeah, those are both excellent questions. So the issue of muscle herniation, if you ask the question or if you let the patients complain about muscle herniation, it's about a 2 to 3% incidence. If you ask the question, do you note any asymmetry of the thigh? It'll be about a 20%. So about 20% of patients will notice some asymmetry of the thigh. We have gone to trying to close down that gap. So we use a suturing device more proximally under the skin. You typically cannot get the IT band back side to side, but it's almost like a suture bridge to try to reduce some of the prominence there. It's not a functional issue, so it doesn't relate to return to sports or strength. And we've never had a case where we have to go back and use a mesh or something to close it back down, but it is something to talk to the patients about, I think, ahead of time, so they're not surprised if they see it after surgery. And then your second question is with growth. And so we've done some MRI studies where we look at the size of the IT band, the length and width of the IT band right after surgery, and then we follow it up with serial MRIs to skeletal maturity. And we do find that the length, as the knee grows, the length of the IT band and the width of the IT band will grow with the knee. Turns out the length tends to grow more than the width of it grows, but it does increase with size as the knee grows.
Now, another question which was discussed briefly about the hyperextension issue, and I know it's a difficult problem, but is it right for me to say that if these kids don't regain their hyperextension, they will be underperforming in their return to sports? How do we deal with this?
Yes, I think that's right. So I think that's why when you're treating these patients, you want them to get back to hyperextension. Similar, but hopefully not as much as their other knee. So I think there is a sweet spot there. If I was going to err, I would be happier if they got the same hyperextension as their other knee than losing motion. Like if they had 20 to 30 degrees on the other knee and they only get to 0 degrees on the operative knee, they tend to have problems with sports, with their running gait, and then they just feel stiff. They complain of stiffness and pain in their knee.
Okay. And obviously, in the interest of time, you couldn't cover the ACL avulsions, but just briefly, two aspects. So there is an MRI classification, which is now being advocated compared to a radiological McEver's classification. Do you see a role for that? And secondly, when we go on to fix it, is it now a more trend towards suture fixation versus a screw fixation?
Yes, I think there is definitely a trend to suture fixation. For example, I did probably screw fixation mostly until about 2010, and now I do almost all suture fixation. I think suture fixation, the advantage is you can use it for any fracture. So if there's a small piece of bone or comminuted piece of bone. Another advantage is it tends to tighten the ACL as well if you pass it through the base of the ACL. So I do like suture fixation. I think screw fixation, has good results as well. And we had good results with screw fixation. It often requires a second surgery to come back and take out the screw. And then MRI for tibial spine fractures, I typically get x-rays for tibial spine fractures. And if they don't reduce, like with extension of the knee or 30 degrees of flexion of the knee, then they go to surgery. And if I'm going to surgery, I will see if there's a meniscal injury and I can treat that meniscal injury. So I don't find MRI that helpful. And if they have a tibial spine fracture, then you're not going to be surprised by an ACL injury because the ACL, it has to be intact to avulse the tibial spine. It may be stretched, but it's intact. If you're going to treat them non-surgically, then I do think an MRI can be helpful because if they have a meniscal tear, that may push you to treating them surgically.
Great. And regarding the OCD topic, the ROC study group have come out with this classification, which you just outlined. Now, obviously, it's an arthroscopic classification. So pre-operatively in the decision-making, how does it really help, or what are the shortcomings of this?
Yeah, I think it's an arthroscopic classification and ROC, and actually we are working on a imaging and MRI classification that's more reliable and guides treatment maybe better than the Hefti classification. And so, we'll see in terms of the ROC imaging classification. I think on imaging, the two key things to me are really, what's the status of the articular cartilage? Is it intact or not intact? And the second is there any instability of the lesion? So is there any gap? Is there any articular fluid behind the lesion? Other things that I find helpful are the chronicity of the lesion. And so do you see subchondral cysts that have formed indicating a chronic lesion? And obviously, what's the status of the physis? Is it open, wide open, closing, or closed? And those are the things that sort of guide treatment. If I see intact articular cartilage, open physes, no cyst formation, no instability, that's a patient I'll treat non-operatively. If I see fissuring of the cartilage or any instability or the physis is closed, that's a patient I'm more likely to treat with surgery initially.
Great. And last question, with regards just a chondral fragment, there are now techniques described where they use sutures and perhaps tapes to refix that cartilage portion. What is your experience and what do you think about it?
Yeah, we published a paper on this fixation of quote, chondral only injuries. And when you look at the chondral piece histologically, it often does have some of the calcified cartilage layer or some bone on it. And in children and adolescents with open growth plates, if you put it back and fix it, it can heal. In our series, it was over 80% went on to heal a chondral only injury. And so I would advocate for trying to fix those, because if they heal, it's sort of a home run. They've kept their own articular cartilage. And that's probably better than a chondral resurfacing technique, which is much more a much bigger operation like MACI or allograft or mosaicplasty.
Great, thank you. IPS, any?
Yeah, no more questions. Thank you.
Great. Really, on behalf of the Indian Arthroscopy Society and me, we are very grateful for you to take time off and talk to us on this topic. And you've shared your years of experience. And we look forward to associations in the future. You mentioned about the Pediatric Orthopedic Society of India. So we look forward to your association with the Adult Arthroscopic Society, although we do end up doing the arthroscopic side of kids' work. So thank you very much once again, and have a great weekend.
Yeah, thank you again for the invitation, and it was a pleasure to be with you.
Thank you. Wonderful. Thank you very much. Friends, it was a wonderful presentation today, and I think we all have learned quite a lot about adolescent and pediatric ACL injuries and cartilage injuries. We do have a webinar which is on 30th of October. It's on 5 p.m. We're going to talk about partial thickness rotator cuff tears. Dr. Stefan Weber is there on this webinar. He's an assistant professor at Johns Hopkins School of Medicine, Baltimore, US, and he's also on the editorial board of the journal. I think this is an important webinar because partial thickness rotator cuff tears are a dilemma, and what is the latest happening? We need to find solutions and answers to it. So do join in on 30th of October at 5 p.m. on IAS YouTube channel for this interesting web-based discussions. Thank you very much and have a nice day.